All right, in chapter 11, we're going to be talking about an example of bioterrorism, specifically focused on the use of anthrax. So let's discuss. Now, bioterrorism and biological threats can come from both natural and human-made sources. So public health professionals have to stay constantly vigilant. Naturally occurring threats, including outbreaks like Ebola, COVID-19, while others involve bacterial toxins in our food supply, such as E. coli producing a Shiga toxin. Human-caused threats can result from accidental lab releases or intentional biological attacks. A powerful example is the 2001 anthrax attacks, also known as Amerithrax. Letters containing anthrax spores were mailed to media outlets and U.S. senators shortly after 9/11. The attacks resulted in 22 confirmed cases and 5 deaths, highlighting how biological threats can create national fear and require rapid public health response. In the 1990s, concern about biological attacks in the US started gaining real political attention. That anxiety was fueled by emerging infectious diseases, the HIV/AIDS epidemic, rising drug resistance, and evidence of biological weapons programs in countries like Russia and Iraq. High-profile terrorist incidents like the sarin gas attack in Tokyo also raised alarms about non-state actors. By 2000, the U.S. National Intelligence Council warned that infectious diseases could complicate national and global security over the next 2 decades. At the same time, it became clear the U.S. public health system was underprepared. We had outdated labs, staffing shortages, weak communication systems, and few hospital response plans. Although legislation was passed, meaningful investment lagged, setting a stage for reforms after the 2001 anthrax attacks. Anthrax is an infectious disease caused by the spore-forming bacterium Bacillus anthracis. It is rare in humans and usually spreads from infected animals, not person to person. Infection depends on exposure route, cutaneous, gastrointestinal, inhalation, or injection. In the 2001 attacks, victims developed either cutaneous or inhalation anthrax. Cutaneous anthrax enters through a skin wound and is usually mild, causing a localized sore. Inhalation anthrax, however, is much more severe. It starts like the flu, but can rapidly progress to respiratory failure and shock. Of the 22 cases in 2001, all 5 deaths were from inhalation anthrax. Because its spores are durable, long-lasting, and capable of deliberate release, Bacillus anthracis is classified as a Tier 1 biological threat. In 2001, 2 waves of anthrax-laced letters were mailed from Trenton, New Jersey, first to media outlets like the New York Post and the NBC News, and later to U.S. senators in Washington, D.C. The letters contained 2 different forms of anthrax: a coarse powder mostly linked to cutaneous cases, and a fine powder associated with the more deadly inhalation cases. In total, 22 people were infected and 5 died. Victims included media staff, postal workers, and civilians exposed through cross-contaminated mail. The contamination spread widely. Over 50 locations tested positive. 35 mail facilities were affected, and 2 remained closed for more than 2 years. After the 2001 anthrax attacks, the FBI launched a 7-year investigation known as the Amerithrax Task Force. It involved dozens of investigators, over 10,000 interviews, thousands of evidence items, and extensive environmental and genetic testing. The anthrax was identified as the Ames strain, commonly used in research labs and not genetically engineered. Ultimately, investigators concluded that Dr. Bruce Ivins, a scientist at US AMRID with access to the strain, was the most likely perpetrator. Although he died by suicide before the indictment, the FBI stated that the evidence suggested he acted alone. The anthrax response was complicated because multiple regions were affected at the same time, unlike typical outbreaks that start locally and expand. Initially, surveillance followed the traditional model. Local and state health departments collected data, relying on frontline clinicians to spot unusual patterns. The investigation began in Florida when Robert Stevens was suspected of having anthrax. Local and state health officials launched enhanced surveillance, environmental sampling, and case finding with CDC support once anthrax was confirmed. By mid-October, confirmed cases in Florida and New York led the CDC to publicly state that the exposures were intentional. During the anthrax attacks, public health used a coordinated two-pronged strategy. First, they investigated confirmed or suspect cases. At the same time, they expanded surveillance nationwide to detect additional cases. The CDC led overall coordination, deployed over 100 epidemic intelligence service officers, and supported state and local health departments, especially in the major epicenters. Hospitals and clinics played a key role. Providers reported suspicious cases, medical records were reviewed, and any cases meeting the surveillance definition were forwarded to the CDC. Suspected contaminated sites were also environmentally sampled. It was truly a collaboration between frontline clinicians and epidemiologists to contain the threat quickly. Now, one of the biggest challenges during the anthrax attacks was simply lack of experience. Human anthrax cases were extremely rare in the US, especially inhalational anthrax, so most clinicians had never seen a case before. They urgently needed guidance on how to distinguish anthrax from common illnesses like influenza, particularly because early detection improved survival. But even the CDC had limited practical experience and had to quickly assemble expert input and scientific literature before issuing guidance. This caused some delays. To help, CDC published clinical flowcharts in the MMWR outlining symptoms, diagnostic tests, treatments, and when to notify public health. However, updates were weekly, and that limited how quickly information reached the frontline providers. Communication during the anthrax response was mixed but generally functional. At the local and state levels, things worked reasonably well because communication channels already existed, and added conference calls helped keep information flowing. Still, coordination became more complicated in areas with overlapping jurisdictions. Between public health agencies and hospitals, communication was fairly effective but often inconsistent. Information was shared through faxes, emails, websites, hotlines, and conference calls. In DC, hospital association calls were especially helpful for sharing clinical observations. However, reaching private practice physicians was much harder. Relying on doctors to pass along public health information didn't always ensure consistent or complete coverage. During the anthrax attacks, the CDC struggled to keep up with the sheer volume of incoming information and to quickly turn that into clear guidance. Initially, they relied on systems like the Health Alert Network, MMWR reports, and EpiX to communicate. But as the situation evolved rapidly, those tools weren't always faster or flexible enough, and more frequent media communication became necessary. Communication was also complicated by the parallel criminal investigation. Some information gathered for law enforcement purposes wasn't immediately shared with public health officials, and there were limits on what could be passed along to clinicians, which slowed down response efforts. During the anthrax attacks, major news organizations played a huge role in shaping public understanding. They didn't just report case counts, they explained what anthrax is, how it spreads, what symptoms look like, and how it's treated. While some online sources fueled the fear, even promoting prophylactic antibiotics, a mainstream like most mainstream outlets generally try to reduce panic by emphasizing that anthrax is not spread person to person and that exposure didn't automatically mean you're going to get sick. This highlights an important public health competency: tailoring communication to different audiences. Getting accurate information from public health agencies to the media wasn't always smooth, especially early on, but choosing the right message for the right audience is critical during a crisis. One of the biggest challenges during the anthrax attacks was inconsistent information. The situation was evolving quickly, and different regions were experiencing different developments. So reporting sometimes became outdated or even contradictory. A good example was the confusion over whether ciprofloxacin or doxycycline should be used for prophylaxis. We saw a similar issue years later during COVID-19, especially around mask guidance. When messaging shifts without clear explanation, public trust can be eroded. This really underscores the role of public health officials. It's not enough to communicate just with clinicians. They also have to communicate clearly with the media and directly with the public. In today's nonstop information environment, that means providing timely, transparent, empathetic updates, even when the evidence is still evolving. One of the key lessons from the anthrax attacks was the importance of partnerships. Law enforcement, EMS, fire departments, and public health were all involved in surveillance and investigation. In many cases, police or fire were the first to respond to suspicious packages, and they worked closely with health departments before samples were even sent to the labs. It really highlights that strong relationships need to be built before a crisis hits, not during it. There was also a shift in thinking about community involvement. Traditionally, civilians were not seen as central to bioterrorism response, but after the attacks, it became clear that the public can be a powerful surveillance and communication resource. Engaging communities not only helps spread accurate information, but can also surface deeper issues like structural inequities that affect vulnerability. Now, as the anthrax response unfolded, agencies had to build the plane while they were flying it. Frontline policies had to be created quickly. Who needed prophylaxis, what PPE to use, and how testing would work, as well as who needed that, what information, and when. That required coordination not just with public health and law enforcement, but also the Postal Service environmental agencies, and even the military. These partners hadn't always been built into earlier plans. At the same time, communities had to rapidly stand up screening and prophylaxis clinics, sometimes within 24 hours, figuring out staffing, supplies, locations on the fly. Federally, the CDC relied on expert working groups to continually update guidance as new information came in, which meant policies evolved through the event. One important distinction in bioterrorism is overt versus covert attacks. In an overt attack, it's immediately clear that something intentional has happened. In a covert attack, it may initially look like a natural outbreak. And this was the case with the first anthrax patient. Only after additional cases appeared did it become clear that this was deliberate. That distinction matters because it affects how public health and law enforcement balance their roles. During the anthrax response, both had to coordinate closely so that investigations didn't interfere with each other. It also highlighted the long-term need for stronger partnerships between law enforcement and public health, as well as clear policies around information sharing during bioterrorism events. During the attacks, most people who sought medical care were actually concerned and potentially exposed, but not infected. Many went to their regular providers or emergency rooms out of fear and uncertainty. The largest group receiving medical intervention were those placed on post exposure prophylaxis. Over 32,000 individuals started antimicrobial therapy after possible exposure, and about 10,000 people in 6 epicenters were advised to complete a full 60-day course due to confirmed exposure risk. Ciprofloxacin and doxycycline were the primary medications used, with amoxicillin reserved for children and pregnant women because of safety concerns. Prophylaxis was recommended for people who had been in locations with confirmed inhalational anthrax cases, areas with environmental contamination and risk of aerosolization, or sites where contaminated letters had been opened. To manage this, centralized distribution and refill clinics were rapidly established, and medications were supplied through the National Pharmaceutical Stockpile. This response highlights both the scale of precautionary treatment and the logistical complexity of managing mass prophylaxis during a bioterrorism event. During the event, laboratories were overwhelmed. The Laboratory Response Network processed over 120,000 samples in just a few months. In New York City alone, the Public Health Lab went from 2 staff handling suspected bioterrorism samples to 75 per shift. Even labs not originally designated for this role began receiving environmental specimens. Staffing was equally strained. The CDC deployed more than 350 employees, including most of its epidemic intelligence service officers, yet state and local systems still struggled. Staff were pulled from other duties, often with minimal training, and routine public health work had to pause. The lesson is clear. Surge capacity requires planning before a crisis. Without trained personnel, scalable systems, and strong leadership, even well-resourced public health systems can be pushed to their limits. The anthrax attacks exposed both strengths and weaknesses in public health response. A federal review found that existing emergency plans helped state and local agencies communicate reasonably well, and the CDC provided strong on the ground support. But there were clear gaps. CDC struggled to rapidly synthesize incoming information and issue timely guidance. Communication with the media and public was inconsistent, messaging sometimes conflicted, and the strain on the workforce and resources was unsustainable. The long-term impact was major federal investment, about $3 billion in 2002, to strengthen preparedness. This led to improved laboratory capacity, better electronic communication systems, stronger surge planning, and CDC approved bioterrorism response plans in all 50 states. Research also surged, dramatically expanding the evidence base for diagnosis, treatment, and decontamination. The 2001 anthrax attacks were an unprecedented public health crisis. They tested a system that was increasingly aware of bioterrorism threats but not fully prepared. The disease was rare, unfamiliar to most clinicians, occurred in multiple locations at once, and unfolded during an already tense national moment. The attacks exposed key gaps, especially in communication and surge capacity. Improvements identified included holding regular briefings, preemptively training staff, strengthening flexible surge capacity, and maintaining clear coordination protocols across agencies. Importantly, these lessons extend beyond anthrax. The experience helped strengthen broader public health preparedness and continues to inform responses to future public health emergencies.